introduction. Then Dr. Irfan Agha from Medical City of Dallas Hospital is going to talk to you about the pathophysiology of glomerulonephritis and will be a little bit detailed about different mechanisms of glomerular injury.
In this video, we're going to talk about the main mechanisms of glomerulonephritis. So I'm going to abbreviate glomerulonephritis and just say GN for short. But essentially what we're talking about is inflammation in the glomerulus. So just to orient you, we're looking at cross-section of a capillary loop of a glomerulus. And so this is the capillary. Here is the endothelial cell lining the capillary. Here's the glomerular basement membrane in pink right here. And then on top is the podocyte. And you can see these little foot processes as they're sort of sticking out and interdigitating with each other. And then down here is the mesangium. And so I've drawn a few mesangial cells, and they're sort of the glue that's sort of holding everything together. So we're going to talk about the main mechanisms for glomerulonephritis. And the first one is immune complex-mediated disease. So immune complex-mediated GN is a very important cause of glomerulonephritis. There are so many diseases included in this category, and so it's definitely worth paying attention to. And so for our diagram here, I'm going to add some immune complex deposits. So you can see now that they're lining the endothelial cell. And essentially what happens is that when I'm talking about an immune complex, I mean there's an antibody binding some antigen, okay? And so an antigen plus antibody equals the immune complex. You may be wondering, what are the antigens? Well, here they are. Could be anything like a bacterial antigen or a viral antigen, which would be exogenous type antigens. These could be autoantigens, so nuclear antigens, things that came from your own body, or the antigen could be a second antibody. So one antibody is binding another antibody, which is sort of acting like the antigen in the complex. Now within immune complex-mediated disease, there are a couple different mechanisms for how immune complexes actually cause the inflammation. For one, there could be circulating immune complexes. So a circulating antigen binds with a circulating antibody. And these immune complexes can now deposit in the glomerulus. And so some of these can deposit in the mesangial area, and some can deposit in the subendothelial area. And keep in mind, the whole point of the antibody is to help stimulate the immune system and direct its attention at wherever the antibody is. And so this Fc portion of antibody is there to recruit inflammatory cells like neutrophils. And also some antibodies can activate complement. And so remember, complement can be activated by an antibody through the classical pathway. And once complement is activated, it also recruits inflammatory cells, and it also generates the membrane attack complex, which is directly cytotoxic to cells. So once complement is activated, more inflammation occurs. And ultimately, inflammatory cells like neutrophils will arrive, and they will have direct cytotoxic effect on all portions of the glomerulus. Alternatively, you could have a circulating antigen that first gets planted into the glomerulus, and then these planted antigens can now be bound by some circulating antibody. So in this situation, the immune complexes are sort of formed in situ within the glomerulus itself. Next, the end result is similar. Inflammatory cells are recruited and cause inflammation and eventual destruction. Next, one final mechanism is where some circulating antibody is actually binding directly to the glomerular basement membrane. And so this antibody here is reacting against the glomerular basement membrane, and this disease is called anti-GBM disease or anti-glomerular basement membrane disease. Since these antibodies will recruit inflammatory cells, there will be subsequent inflammation and typically a necrotizing glomerulonephritis. So examples of immune complex-mediated GN includes lupus nephritis, the infection-associated GNs, or they used to be called post-infectious glomerulonephritis. There's also an HIV immune complex kidney disease, IgA nephropathy, cryoglobulinemic GN, and also, as I mentioned before, anti-GBM disease. The next important mechanism is through dysregulation of the alternative complement pathway. So with immune complex-mediated disease, we did talk about complement briefly, and when an antibody mediates the complement pathway and activates it, that's through what we call the classical pathway. But there's this other thing called the alternative complement pathway, which does not require immune complexes. So we mentioned complement when we were talking about immune complex-mediated disease. So immune complexes can activate complement, but they activate it through something called the classical pathway. The alternative complement pathway does not require immune globulins, and it's activated slightly differently. And so it's part of our innate immune system, and we have circulating parts of the alternative complement pathway that are always a little bit activated and sort of surveying the situation. And so if they come across some foreign cell, like a bacteria or fungus or something, or if there's damaged tissue or damaged cells, it will actually start to activate, and it sort of self-propagates in a feed-forward mechanism so that we can activate complement in an antibody-independent manner. Okay, and so if this is occurring, you probably are thinking, well, we need to make sure that our body doesn't auto-react against itself and cause a lot of damage. And you're right. And because of that, we have an elegant system of checks and balances on this. And so we have to have a lot of auto-regulatory proteins and things to keep this alternative complement pathway from getting out of control. Unfortunately, sometimes that happens. And when the alternative complement pathway gets out of control, it can attack the kidney, and more specifically, it can attack the glomerulus and thus induce inflammation. So just like the classical pathway, when the alternative complement pathway gets activated, it recruits inflammatory cells. So here are neutrophils showing up, causing inflammation. And then it also generates the membrane attack complex, which is directly toxic to cells. So you're probably wondering how on earth this could actually happen. And it usually requires a combination of things to get this set in motion. And so first, usually requires some sort of environmental insult, whether it's an infection or trauma or endothelial damage. Okay, so that has to happen first to sort of start the process. And then the patient typically has to have one of these two things, either an acquired inhibitor to the alternative complement pathway, so maybe they have some new antibody that just happens to be binding one of those regulatory proteins, or patient has a genetic mutation in one of those regulatory proteins, such that the alternative complement pathway, when activated, is overactive, can't shut down on its own, and not controlled under normal circumstances. And so unregulated activation of this can cause an aggressive GN like we see here. So here are some examples of these diseases. There's a catch-all term called the C3 glomerulopathies that includes a disease called C3GN and also another disease called dense deposit disease. And then there's also a group of diseases called atypical hemolytic uremic syndrome, which are mediated by abnormal complement deposition from the alternative complement pathway, but you also see a thrombotic microangiopathy, which leads to microthrombi forming in the glomerulus and the capillaries, and this also results in kidney failure, but you also have evidence of a microangiopathic hemolytic anemia. So the final major mechanism of GN worth mentioning is through neutrophil activation by autoantigens. So you may have heard of some of these diseases before, and these diseases involve what we call ANCAs, anti-neutrophil cytoplasmic autoantibodies. And so here's how they work. Here are circulating neutrophils just sort of minding their own business, not causing any trouble, but in the presence of ANCAs, these anti-neutrophil cytoplasmic autoantibodies, they bind to certain autoantigens on the neutrophils, and when this happens, the neutrophils become abnormally activated, and when they're activated, they're going to attack different tissues. They're going to attack the endothelial cells. As a result, these neutrophils, when they destroy endothelial cells and cause cell lysis, that actually recruits more inflammation to the area, and so it results in a vasculitis. And as I mentioned, this can occur in other organs, but when it happens in the kidney, it affects the glomerulus because that's where our capillaries are. So there's a number of diseases that are mediated by these ANCAs. There's granulomatosis with polyangiitis, microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, and each of these three diseases not only can involve the kidney but other organs or systems. And then there's something called the renal-limited ANCA vasculitis, where this disease is only affecting the glomerulus. So those are the three main mechanisms for how we can get glomerulonephritis. And so next, we're going to go into a little more detail with specific diseases.
This is not a terribly deep dive, but an overview, and it is actually meant to set the stage for the lectures that we have planned for you for the rest of the year. It will kind of sequence into that. So when we talk about membranous glomerulopathy today, it will set the stage for what Omar is going to talk about, I think, next month about that disease process. So this is an original paper that Arthur Ellis wrote in 1942. He was studying the natural history of what was at that time known as Bright's disease. That's the first catch-all phrase for all sorts of proteinuric kidney disease. And he divided, with great prescience, these kidney diseases into two types. And at that time, they were known as Ellis type 1 and type 2 diseases. We now know them as nephritic and nephrotic syndromes. But he tried to parse together, parse apart, actually, two main varieties of disease. One of them was an angry, fast-moving, hematuria proteinuric, loss of GFR type phenotype, whereas the other one was a relatively more insidious proteinuric, anosarchic, slow loss of GFR phenotype. And, we call them as nephritic and nephrotic syndromes today. But the interesting thing is that, after all this time, we're still in that paradigm. So this is the podocyte view. So you're looking from the urinary space onto the podocytes. And this is the endothelial cell view, where you're looking at the endothelial cell from within the capillary lumen of the glomerulus. You can look at this fenestrated endothelium here. And essentially, Ellis type 2 diseases, the nephroses, are diseases of the podocyte, whereas everything else that causes the angry, hematuric, loss of GFR type phenotype is a disease either of the glomerular basement membrane or of the endothelial cell. And so the one message that I would make today before we launch into the various phenotypes that we come across in the way we have traditionally classified kidney disease is that these are histopathological entities, each one of them, minimal change disease, focal segmental glomerulosclerosis, membranous MPGN. These are all histopathologic entities. They're not diagnoses. So after having learned about these diseases for over 75 years now, we need to be on a very strong pathophysiologic keel to define these disease processes and then figuring out how to treat them in our patients. So this is how I have tried to bunch them together today. So we are going to talk about podocytopathies. We're going to talk about membranous. Membranous is technically a podocytopathy, but since it is so very different from FSGS and minimal change disease, I think it merits its own class. I'm going to skip over the disorders of the glomerular basement membrane. I had to sacrifice some things today just in the interest of time. There was not enough time to do all of this. We will talk about proliferative diseases. We'll talk about focal necrotizing vasculitis and crescentic disease. And then finally, we'll talk about thrombotic microangiopathy. Again, anything below this line is Ellis type 1. Anything above this line is Ellis type 2. So the classification from almost 80 years ago still has pertinence. Also notably absent from today's discussion are going to be disorders like diabetes and hypertension. I kind of focused more on the immunological basis of these diseases. So podocytopathies are disorders of the podocyte. So these are on the outside of the glomerular basement membrane, and these lead to various proteinuric phenotypes. As a group, GFR loss is very late now and very florid. Minimal change disease or focal sclerosis, you can sometimes see an ATN and loss of GFR, but permanent loss of GFR is a late feature in podocytopathies, and these typically present with the nephrotic syndrome, but there are many phenotypes and different shades of these diseases that would present with slowly progressive proteinuria and slowly progressive loss of GFR as well. Now, the podocyte is a very, very active cell type. It's a terminally differentiated cell, so the ability of this cell to divide is limited. There's about 800 podocytes in each glomerulus, and once you lose a bunch of these podocytes, the glomerulus is not going to recover from that, as we will see in a second. And I'm not going to go over all of these details. The only reason I put this up is to highlight the intricacy of the cytoskeletal elements and the membrane elements that the podocyte has. So this is a blown up cartoon of the podocyte foot processes, the glomerular basement membrane and the glomerular capillary endothelium. So this is a fenestrated epithelium, as we know. This is the glomerular capillary lumen. So we're looking from inside the lumen towards the basement membrane and then towards the urinary space here. The podocytes sit on the glomerular basement membrane through several different types of molecule. The integrins, the alpha-3 beta 1 is the commonest. There's molecules called syndicons and dystroglycans, and these actually set the podocyte on the glomerular basement membrane. But more importantly, these integrins are actually in very, very close communication with the actin cytoskeleton inside these podocytes. Molecules like integrin-linked kinase, ILK here, or focal adhesion kinase here actually signal with the actin cytoskeleton and help the basolateral part of the foot process communicate with what's going on inside. Pressure changes from within the capillary lumen are actually transmitted to the podocyte, and the podocytes on this part of the glomerular capillary tuft actually work as pericytes, and they modulate that pressure. And it is thought that along with loss of slit diaphragm function, it is loss of this pressure function that permits proteinuria when there's a widespread foot process disturbance. On the side-to-side side of the foot processes here, there's these proteins that span between the edges of adjacent foot processes. Nephrin and F1 and F2 type proteins span the bridge, and there's conglomeration of proteins on the inside that signal with this slit diaphragm along to the actin cytoskeleton. So once there are changes in the actin cytoskeleton, the slit diaphragm function can change as well, and mutatis mutandis. So when the podocyte is injured due to whatever reason, and we'll go over some of these reasons in a little bit, the first thing that the podocyte does is it starts retracting. It separates from where it is anchored into the glomerular basement membrane, and it simplifies or effaces. The foot processes actually vanish because the whole thing has moved up. And once the foot processes efface, the slit diaphragms start malfunctioning. Once the slit diaphragms malfunction, you have leakage of albumin through this barrier. So this then is the basis of dysfunction of the podocytes. When the podocytes are injured, there's several morphological changes that happen. We've talked about the derangement of the actin cytoskeleton, which causes effacement or simplification of the foot processes. That leads to malfunction of the slit diaphragms. It causes several cysts and microvillus changes that start developing in the podocyte. And we can actually see this on electron microscopy. And the podocyte starts lifting up, which increases the subpodocyte space on the glomerular basement membrane. And it is this injury to the podocyte which then leads to malfunction of the glomerular filtration barrier and proteinuria. Now, if this injury is finite and we are able to control it, this can actually get better because some of these changes are just cytoskeletal active changes. But if the injury persists, then the podocytes are going to detach from this membrane and fall off into the urinary space. And if you lose about 40% of podocytes in that glomerulus, that's the point of no return. And after that, the glomerulus may not recover from this injury. So this is what happens in minimal change disease due to some immune trigger. There is antigen there's crosstalk between T and B cells, and there's elucidation of factors both from the B cell side as well as the T cell side. There's this circulating factor that we have been talking about for 25 years or even more than that. We have not been able to identify it. We came pretty close, we thought, a few years ago with SUPAR, but that has not panned out. There's actually several different cytokine soups that are elucidated from the T cells as well. And minimal change disease, and we've known this forever, is probably more a disease of T cells than it is B cells. But there are different flavors of this. So if you've got more of a circulating factor type disease, it is going to behave more like an FSGS, early FSGS phenotype. Whereas if you've got certain lymphocyte subset imbalances, it imparts certain characteristics. So for instance, if there's a Th17 imbalance, then you might actually come across a phenotype of minimal change disease, which is resistant to steroids or subresponsive to steroids and actually responds to cyclosporin. And it is also very important to know that we thought originally that most of our therapy was working on minimal change disease through immunosuppression. So cyclosporin was thought to attenuate the T cell response. Rituximab, for instance, was thought to cause B cell depletion. And some of this may still be true, but there are non-immune structural targets for both cyclosporin and rituximab, calcineurin inhibitors and rituximab, which actually lead to cytoskeletal stability of the podocyte. So cyclosporin actually acts on synaptopodin, whereas rituximab can actually attach to a protein called SMDP3B, which imparts cytoskeletal stability and may work through a non-immune mechanism. So whatever the mechanism here, once you've got that injurious agent coming in, the podocytes are going to get damaged. They will simplify, foot processes are going to get disease, and you'll have leakage of albumin. But the glomerulus in minimal change disease looks completely normal on light microscopy. That's why it's called minimal change disease. So this is Mason's trichrome. You have these delicate capillary loops. They're all open. The mesangium is not expanded. There's no mesangial hypercellularity. You see 1 or 2 cells per tuft here. Per loop here. And so if you looked at this under the light microscope, you would say this is completely normal. Again, just to orient oneself, this is a parietal epithelial cell. This is a podocyte sitting on the outside of the capillary, and this is an endothelial cell on the inside of the capillary. So this looks pretty normal. So this is the nature of injury, podocyte injury in minimal change disease. And this is exactly replicated in FSGS as well. So you may have a genetic predisposition to developing podocyte injury. You may have a circulating factor, be it SUPAR or some other yet unknown factor, mechanical issues like stretch in cases of hypertension, toxins, infections, etc., etc. All of these are going to cause podocyte injury. The podocytes are going to get into trouble. Some of them will detach. Some of them will die, and you'll have podocyte depletion. Now, if you're able to repair this, and if the injury is overcome, then you will probably see some form of recovery or repair. But if you have significant loss of podocytes, then your numbers are going to go down. And even if the injury is resolved, you will develop progressive FSGS. So let's see, why would that happen? So this is what happens when you get podocyte injury. Podocytes, like I said, are terminally differentiated cells, but when they're injured, when they're in distress, they re-enter into the G1 and S phases and initiate DNA replication, but they are locked, they're jailed from completing their mitosis. This is actually an anti-cancer protection mechanism, but that works in podocytes as well. And essentially what happens is that they cannot pass through the M phase owing to initiation of what is known as mitotic catastrophe. This is how the body protects itself from cancer. And what happens with mitotic catastrophe is that the podocytes either become really large because they've already completed their DNA replication, and this is what you see in cases of FSGS, hypertrophy of podocytes, and due to catastrophic mitosis, which you can see these mitotic figures here, you can actually see multinucleated podocytes here, and then these die, and then they can fall off. So this is a podocyte that's actually stained, a multinucleated podocyte that's stained in the urinary space. So once you're losing podocytes, like I said, that you're going to get into trouble if you develop podocytopenia. And if you lose about 40% of the 800 podocytes that reside in any glomerulus, you will pass the point of no return and eventually develop glomerulosclerosis. So let's see how that happens. So this is a glomerulus in which you've had foot process effacement due to injury to the podocytes. So now this leads to denudation of the glomerular basement membrane. Once enough podocyte damage has happened, the glomerular basement membrane, which is now denuded on the epithelial side, bulges and makes contact with the parietal epithelium. This is known as a synechia, a bridge that forms between the glomerular basement membrane and the parietal epithelial cells. And this is actually something that you're seeing on this picture on the right side. So instead of that very nice open capillary structure that you saw on Mason's trichrome, what you see here is like a battle scene. You've got this glomerulus, which is abutting the parietal epithelial cells. This is known as a tuft adhesion. And now the parietal epithelial cells are coming into the melee. You're seeing the podocyte hyperplasia, which is a manifestation of injury. And once this continues, you're going to see hyaline in these capillary loops. You're going to see the tuft adhesion right here. And what then happens is that there is a reaction in the parietal epithelial cells. We used to think that this is all podocyte hyperplasia that happens, and multiplication that happens. What we know that podocytes, although can increase in size, but they can't multiply because of the mitotic catastrophe scenario that we just talked about. So it is thought that the parietal epithelial cells actually migrate down this tuft adhesion and they start multiplying. So this is what you start seeing in this glomerulus, and eventually this all scars down. So this is a fully formed segmental sclerosis scar. Capillary loops are all dead, and there's areas of trapped hyaline, which you can see here. And if I really imagine you can see some highline over there. So this is the pathogenesis of the focal segmental scar. And if you've got minimal change disease that stays long, doesn't respond, and causes enough podocyte damage, it will actually move this side as well, in this direction as well. So we used to think that, oh, if minimal change disease is not responding, it must have been FSGS that we didn't sample. That may be true, or it may be that the minimal change disease has damaged the kidney so much that now you have developed a secondary FSGS scar in there. So this is a cartoon. This is out of Virginia Savin's paper, which actually is looking at management strategies for FSGS. So how do we translate all this basic pathophysiology into science? And it's still know what these factors are. So we're calling some cytokine, some factor, permeability, inducing moiety, which causes problems by attaching to certain receptors on podocyte, and then it causes cytoskeletal abnormalities, changes in the podocyte, damage to the podocyte, maybe podocyte death, and then eventually development of an FSGS scar. And if you catch these things early, and in these weeks matter, so if you look at recurrent FSGS in kidney transplantation, the sooner you get to treating somebody, that affects your outcomes. If you get to somebody right at the beginning, within the first week or 10 days, your chances of getting a remission are much higher than if you get to them at 4 weeks or 6 weeks. And even in that short period of time, the disease marches, it progresses. And this is also why plasmapheresis doesn't work in native kidney FSGS, but it does in recurrent FSGS, because you can catch it so early, you're looking for it. So you can actually decrease cytokine concentration. We can do this by plasma exchange. We can do this by immunosuppression, hoping that the generation of some of this cytokine soup will go down. For instance, by using rituximab, by using cyclosporin. Then we are working on inhibiting the signaling catastrophes that happen. So again, rituximab acts on sphingomyelin phosphodiesterase 3B, SND3B, cyclosporin acts on synaptopodin. There are other small molecules being developed which would actually attenuate the signaling problems that come up when one of these toxic cytokines is affecting the podocyte. I think the most notable example of this is the APOL1 gene product, which we know is released by the podocytes. If you have APOL gene mutations, that product from the mutated gene assembly is toxic to the podocytes, and there are small molecules being developed right now. Some of them are in trial, where you would block those small molecules and avoid the changes in the cytoskeletal, the signaling changes that lead to cytoskeletal rearrangements in these podocytes. So I think our understanding of these diseases is much more refined today, and we are able to separate what is immune-related versus what is not, and then treat these patients more appropriately. So we will switch gears a little bit and now go to the membranous group of disorders. This is also podocytopathy, but a totally different flavor of podocyte dysfunction. So membranous was first described in 1946 by E.T. Bell, who was a professor of pathology at the University of Minnesota. And he was looking at all the cases of what at that time, like we mentioned, were called Ellis type 2 glomerular disease, the diseases that cause nephroses. And he described nephrotic syndrome occurring with renal disease, which was marked by thickening of the basement membranes. And so that was essentially a very, very cogent description of membranous GN. So the Hayman's nephritis model was developed some 15 years later. This is a paper that was published in 1959. And at that time, Walter Hayman administered Froude's adjuvant to mice intraperitoneally. Now, then what he did was he picked up a group of mice in which he added a rat liver suspension to the Froude's adjuvant, and then in another group he used rat kidney suspension along with the Froude's adjuvant. And what he found was that in the mice that were inoculated with rat kidney suspension and Froude's adjuvant, which actually enhances your immune response, these mice were much more likely to develop severe nephrotic syndrome. At that time, all GNs were thought to be secondary to circulating immune complexes. So the prevalent theory at that time was that when you inoculate the mouse, it generates antibodies against kidneys, circulating immune complexes form, they deposit in the kidney and cause a severe nephrotic syndrome. So the basics of this concept were correct, but the thing obviously that was not correct was that this is not a disease of circulating immune complexes. So Bill Krauser in 1978 carried out this study. Now Bill Krauser is still active in the field, so I mean it's very humbling to see his contributions to the field of membranous glomerulonephritis in 1978. I was in grade school. So he demonstrated that if you had an antibody to FX1A, which is a brush border antigen, but it is also shared by some in the glomerular locations, then you can actually duplicate membranous glomerulopathy in these rats. And the lesions were indistinguishable from rats that had developed membranous glomerulopathy by immunization. So on this panel, this is from living rats. They were immunized with FX1A, developed antibody to it, and developed these lesions. If you look at these podocytes, you're looking at these little subepithelial deposits, whereas if you had on the left panel the isolated rat kidney and perfused it with the antibody, it would go in over here as well. So there was no time for this antibody to form immune complexes. This was in a controlled setting. So this set the stage for identification of the culprit antigen in Hayman's nephritis, and this was GB330 or megalin. We all know megalin is present in human proximal tubules. It is not expressed in human glomeruli though, but in the rat it is. And so when you infuse an anti-megalin antibody, anti-GB330 antibody into these mice, they develop a clear membranous phenotype. But since so this actually clarified how membranous happens, but we couldn't move it into the humans because we had not demonstrated how this disease happened in the human beings, because we don't have megalin on our foot processes. So this was a very nice case report, very neat case report actually, that was presented in 2002, and this was in a case where a female patient who had genetic deficiency of neural endopeptidase was pregnant, and she actually then developed anti-neural endopeptidase antibodies which crossed the placenta. Now this is the baby's kidney. The baby has neural endopeptidase at the foot processes. The antibody crosses the placenta, goes to the baby's kidney, and creates a antigen-antibody complex right at the glomerular foot process, activates complement, and leads to severe neonatal nephrotic syndrome. So this was the first demonstration of an in situ immune complex formation. So this proved the concept that this happens in man. The disease is because of in situ immune complex formation. But the neutral endopeptidase deficiency in this scenario is an extremely rare scenario. So we still didn't know what the target antigen is in human beings. This mystery was solved by Larry Beck and Dave Salant in 2009. I think this is one of the most consequential papers in the science of membranous glomerulopathy. What they did was they picked up sera from patients with idiopathic membranous nephropathy. So these sera had antibodies to whatever target antigen they were attacking, right? And they dwelt it with normal immune glomerular tissue. So now you've got glomerular tissue. You're putting in serum, which has got some antibody soup in it, and then they did a Western blot analysis of this contraption. And what they found was that in patients with idiopathic membranous nephropathy, sera from idiopathic membranous nephropathy, all of those were actually reacting with a 185 kilodalton protein. They also took sera from patients who didn't have membranous nephropathy, so somebody with FSGS or diabetes or SLE, and so all these patients had no reactivity. So clearly, in the sera of patients with idiopathic membranous nephropathy, there was an antibody which was reacting at a 185 kilodalton band range. I would ignore this. This is PNGK. So this actually is an enzyme called peptide N-glycosidase F, which causes a substantial shift in the location of these complexes, indicating that the protein, whatever this protein is heavily glycosylated. So we're going to focus just on all the idiopathic membranous nephropathy band now, and 70% of these sera were reacting with this 185 kilodalton protein, and we today call this protein as phospholipase A2. So this essentially is the beginning of the modern era of the science of membranous nephropathy, where we actually understand what's going on. So this is just this picture from the Salant and Beck paper from New England Journal of Medicine. Panel A is where you're actually staining with PLA2R antibody, so it's lighting up. This is control. So what they've done is they've pre-treated this panel with recombinant CTLD 5 to 6, which is CTLD C-type lectin-like domain. This is a blocking recombinant fragment, so it doesn't allow your PLA2R antibody to attach to the PLA2R antigen. This is just non-specific background staining in the tubule. And so they then tried to figure out where this reaction is happening. So panel D is what they've done is stained it with agrin, anti-agrin antibody, which stains the basement membrane. So what you're seeing here is that the redness is on the outside of the basement membrane. On the right side, again, they've got the blocking antibody, so the basement membrane is all being stained, but you don't see any red here. And then what they did was they stained the tissue with WT1, which stains the epithelium and the podocyte nuclei. So all these green things here are the podocyte nuclei. So you can actually see that the red is underneath the podocyte nuclei, outside the glomerular basement membrane. So it's probably in the some podocyte space. And this is what a PLA2R antibody molecule looks like. And so this actually crystallized the understanding that we have of membranous glomerulopathy today. Beck and Salant also noticed that once you treat it with steroids or other immunosuppressive agents, this molecule, this band that we were seeing has gone away. And just as the urinary protein-creatinine ratio has come down, so with remission, it looks like the PLA2R antibody level in the blood goes down. So how does proteinuria happen in membranous? So the antibodies actually cross the glomerular basement membrane, attached to the PLA2R antigen. With the podocytes, the antigen antibody complex is shed, but it picks up complement, activates complement, and once complement is activated and a sublytic membrane attack complex is formed, it leads to cytoskeletal changes inside the podocyte, causes endoplasmic reticulum stress, and also leads to generation of reactive oxygen species, which actually are toxic not only to the podocyte but to the glomerular basement membrane as well. And so this is what leads to proteinuria. Now understand that in membranous, the area where complement is being generated and where the problem is barricaded, right? All the inflammatory cells are on the other side of the glomerular basement membrane. So in membranes, you're not going to see any inflammatory cells here. All you're going to see is slow damage to these podocytes, which manifests as proteinuria. And once this sits for a long period of time, you're going to have podocyte loss. So membranous is a slow ramp on disease. It is a slow ramp off disease. So when you start treating it, when you give somebody rituximab for membranous GN, the PLA2R antibody in the blood starts dropping in 3 months, 4 months, 5 months, and the proteinuria response follows that. It lags behind that even. So your proteinuria response may be delayed 6 months, 12 months, 18 months. And so this is a slow, if you're seeing that added for a long and you're in trouble and that kidney is not going to do well. This is in distinction to the proliferative diseases where somebody with lupus, diffuse lupus proliferative GN may come in with a creatinine of 5, and you treat them and their creatinine will go back down to 0.8 or 0.9 because that's an acute inflammatory condition. This is not. So this is the paradigm. I've used it for PLA2R antibody-associated membranous, but it could be for any or all of these. And so your antibody is generated. It interacts with phospholipase receptor at the bottom of the podocyte. Eventually, podocytes are injured because of complement activity, and we'll talk about the complement activity in a little bit, and the podocytes eventually die. So your PLA2R antibody usually starts coming up before you see anything else. It predates proteinuria in most cases, not in all. Proteinuria then follows, and then renal failure follows. And so if you start treating it, the same sequence happens. The first thing that goes down is PLA2R antibody. So you have a serologic response, and then you have a clinical response. So this is a scheme. I'm going to use the same picture throughout today so that we get comfortable with this. Complement can be activated through multiple avenues. The classical pathway, your antigen interface molecule is a C1q here, which is our classic lectin, this bouquet formation. These are the back pattern recognition areas of this. On the lectin pathway, mannose binding lectin, which is again of colectin, looks exactly like a C1q molecule, but their target patterns are different. So C1q identifies an antigen and an antibody. Mannose binding lectin would identify carbohydrates and certain other bacterial surfaces. But whichever thing initiates these pathways, they actually go to develop what is known as a C3 convertase by utilizing complement 4 and complement 2. So the C2b4b is the C3 convertase for the lectin or the classical pathways. On the alternate pathway side, the cardinal molecule is C3. C3, unlike the classic or lectin pathway, in the alternate pathway, there's a little bit of what is known as tickover and autohydrolysis of the C3 molecule. So it is always ready to pounce. It is like the Rangers, it's on the boundaries. As soon as they see something, the hydrolyzed C3 can attach to C5 as complement factor B and D and develop the C3 convertase of the alternate pathway. Now, since this is happening at all times, you need this thing controlled, right? So you need complement factor H, complement factor I, membrane cofactor protein, etc., etc. Several of these proteins, and we'll talk about them in increasing complexity throughout the talk today, actually lead to control of this take over so that this doesn't get out of hand. But in the right circumstances, C3 convertases are formed through this cascade on the alternate complement pathway side as well. The C3 convertase, when it's generated, then goes on and activates C5. Once C5 is activated, it leads to generation of the membrane attack complex. Also, breakaway fragments like C3a or C5a are very potent anaphytotoxins. So this is our first exposure to the complement cascade today, and we'll keep talking about it as the day goes along, and my apologies for this in advance, but in today's time, you cannot understand glomerular disease if you do not understand complement. So what causes the problem in membranous is very interesting, because membranous is an IgG4 driven disease. There's only like 14 or 15 diseases in the entire cornucopia of human disease that is driven by IgG4. The other problem is that IgG4 lacks certain residues at its hinge region, and it is actually very, very poor in activating complement through the classic pathway. So how does membranous cause damage? Because we know that when you do an immunofluorescence stain in a patient with membranous, you get IgG and C3. So it sounds like it uses the lectin pathway as well as the alternate pathway. But this is a study looking at the patients who don't have mannose binding lectin. So these are knockout mice with, I'm sorry, these are patients with MBL deficiency or wild type. And patients who are MBL deficient mannose binding lectin, which is the lectin at the first part of the lectin pathway, they don't light up in cases of membranous. But if you're a wild type, or if you've got properidin, which is the alternate pathway, you light up regardless of your lectin proclivities. So essentially, the pathways through which membranous leads to complement activation are lectin and alternate. And this is actually borne out in mass spectrometric studies. So we are now looking at patients who are either controls in blue, or who have PLA2R associated disease in red, or who have exostosin 1 or exostosin 2 associated disease, which are in green. And what you see is a huge amount of C3 and C4 and C4b and C5 and C6, 7, 8, 9, which is the terminal membrane attack complex, etc., in these biopsies. So when you look at those deposits, the subepithelial deposits, this is what you're looking at. You're looking at C3, you're looking at IgG, you're looking at C4, C5, C6, etc. That's what makes those deposits when you look at them under the electron microscope. So the target field for membranous is expanding every day. We're getting a new agent. We understand some of them quite well. Some of them we are beginning to understand, but I will let Umar deal with membranous nephropathy on his talk next month. These are the different stages of evolution of these deposits. The earliest deposits are just blebs in the subpodocyte space. Then they're taken in intramembranously, and eventually they become they start lysing off. They become chronic. And visually, you can actually say stage 1, 2, 3, and 4, which only tells you where these deposits are in their temporal evolution. So this is a case of membranous nephropathy where it is a very early case. This is one of my cases. This was actually a very early recurrence after transplantation. We were watching for it. So if you really look at it, if you showed me this glomerulus outside, this is normal, but there are very, very small, tiny subepithelial deposits here, and this patient was treated in it very well indeed. This is more of a chronic, long-standing membranous. So look at this loop. It almost looks like a pipe. It's really thickened. So even a non-pathologist like myself would be able to say these loops look rigid and thickened. And when you do the when we looked at the electron microscopy, you see these large deposits which are present in the subepithelial space, but also are present in the mesangium here. So this is a case of lupus membranous, and actually in the higher part you can see these tubular reticular inclusions. Secondary membranous in this particular situation. So I'm going to switch gears now and go to proliferative glomerulonephritis. I've got this in the parentheses because we don't use the term proliferative anymore. There's nothing really proliferating in the capillary. We use the term hypercellularity now because it's just infiltration of inflammatory cells. And so what we've done now is we have switched gears from the epithelial side of things to the endothelial side of things. And like I said, I've skipped the glomerular basement membrane disease issues today. And so what we have here is, in case of, for instance, lupus nephritis, we've got antigen antibody complexes or antibodies attacking the target antigens on endothelial cells, which then lead to complement activation, direct cell mediated toxicity, recruitment of inflammatory cells. And it is recruitment of these inflammatory cells that was called proliferation, because you see a lot of cells in the glomerulus. It doesn't matter where the antibody is coming from. So this is lupus on the right side of the things. We have IgA nephropathy. You've got the 4-hit hypothesis. You've got a galactose deficient IgA molecule coming up. This IgA molecule is looked at in the circulation. Your own immune system develops an antibody response against this galactose deficient IgA molecule. These antigen or antibody complexes essentially form in the circulation, and then they can deposit in the kidney as well as in the skin and other capillary beds. But when they deposit in the kidney, they're now actually depositing here in the mesangium. And depending on how abrupt the immune response is, IgA can be just some mesangium deposits all the way to a catastrophic crescentic reaction in the endothelial space. So it's just a matter of damaging the endothelium through different ways, but that leads to proliferation. Now, when this proliferation happens, it can result. So you've got post-infectious glomerulonephritis, you had sore throat, and 3 weeks later you developed an acute post-streptococcal GN. In kids, it almost always resolves completely, and the glomerulus may completely heal itself. But if you have persistent injury, then you have repair processes. Even if it is a crescentic response, it can resolve, or you can get into the persistent injury phase. And at some point, if you've got this persistent injury, you destabilize your underlying complement defects as well, if there are some. And that leads to not just the complement thing, but the repair processes leads to development of the MPGN lesion. MPGN, membranoproliferative glomerulonephritis, is a histopathological entity. All that means is there's two things going on. The first thing is, due to whatever reason, immune complex complement, infection, related immune complex disease, yada, 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 is leading to endothelial damage. And then the endothelial damage is persistent, and you now have started doing some repairs in there. And when you damage the basement membrane through these acute inflammatory conditions, you then deposit these antibodies and complement and other proteins, this debris of cell damage as well, on the basement membrane, or just on top of the injured basement membrane. And on top of that, as part of the reparative process, you throw in another layer of basement membrane. And this then is what we look at as double contours of the glomerular basement membrane, which is a sine qua non of the MPGN lesion. So essentially what you're seeing in an MPGN is injury and repair in the same picture. And this is what an MPGN glomerulus looks like. You can see it is very different from the normal glomerulus I showed you a little while ago. It looks like it's kind of swollen. It is angry. You see a lot of cells. You don't see a lot of capillary lumina. And it looks lobulated. It looks a little bit like the brain, doesn't it? So essentially what's happening here is that there's mesangial expansion. There's infiltration of inflammatory cells. They're blocking the capillary lumina because the endothelial cells are swollen. There's infiltration of cells there. And most cases of MPGN look a little bit like this. So how do you tell them apart? So the first thing you look at is when you see, and this is not an MPGN classification, it is what do you do when you see double contours on microscopy. If the immunofluorescence is positive, you look for subendothelial deposits and you go down the MPGN line. Subendothelial deposits actually are going to tell you that there's activity here. So these are going to be the subendothelial deposits that you'll see on microscopy. Now, sometimes chronic MN can cause double contours if the immunofluorescence is completely negative. You can have that in TMA, and we'll look at some of this. And in the transplant case, you come across this transplant glomerulopathy. But when you see endocapillary hypercellularity, you've got subendothelial deposits, you've got cells in there. You look at the immunofluorescence. If you're seeing IgA there, it's probably IgA. If you see full house immunofluorescence, it's SLE. If you see IgG and C3 and non-organized deposits, you're probably looking at an immune complex GN or another infection. If you're looking at organized deposits, you're probably looking at cryos. If you're looking at monoclonal deposits, you're looking at PGNE. If you see deposits, you're kind of going into the C3 group of disorders. And this is where the line is. All of this is antigen antibody dependent driven. This, on the other hand, is C3 dominant. And this was the insight that the Mayo Group had about 10 years ago. So MPGN, as you remember classically, is actually classified based on the electron microscopy appearance. Type 1 is just subendothelial deposits. Type 2 is dense intramembranous deposits. Type 3 was the subendothelial and subepithelial deposits. But this is a structural or morphological classification. It doesn't tell you why you've got the disease. So what we have done now is we have switched to an immunofluorescence-based classification, which actually is good for people taking care of patients in Pakistan because we don't have electron microscopy readily available there. So if you've got a case of MPGN and your immunoglobulins are positive, you're looking at the classical pathway of things, and you're looking at things like post-infectious or immune complex deposition, your IgA nephropathies and lupuses, certain cancers, especially MGRS-type issues and many other things. Whereas if your immunoglobulins are negative, the only thing that's lighting up is C3, then you're talking about the C3 glomerulopathy group of disorders. And again, C3 glomerulopathy group of disorders is disorders right here. So I told you that C3 autohydrolyzes and takes over, and at any given time requires many different factors to hold its activity. So unless you have complement factor H or complement factor H related protein or factor I or factor membrane cofactor protein, which is CD46, this thing is going to go into overdrive. It will go unchecked. This is in the fluid phase. So this is happening in the blood, which is important to remember when we talk about HUS. So what happens is if you have a problem with complement factor H, either an antibody against it or a genetic mutation leading to underfunction, then the complement factor H is not going to be able to stop this relentless activity of the alternate complement pathway. Alternate complement pathway will go into hyperdrive and start depositing into beds that are vulnerable to this sort of activity, and unfortunately the kidney is one of them. Like I said, that there can be many different things that can cause this hyperactivity on the alternate complement pathway side. You could have antibodies called C3 nephritic factors, which can cause increased activity. You can have mutations in complement regulating genes, or you can have mutations in complement factors. So there are certain activating mutations in C3 as well as factor B that can lead to hyperactivity on the C3 genes on the alternate complement pathway side. And this is what happens. Your light microscopy looks exactly like an MPGN kidney should look like. When you look at immunofluorescence, IgG is negative, IgA is negative, IgM is negative, but the C3 is lighting as a Christmas tree. So this then is C3 glomerulopathy. Now, from time to time when we do immunofluorescence in our patients with MPGN, you find that they've got monoclonal immunoglobulins. So over here, what you're seeing is kappa and IgG3 are lighting up, lambda and other isotypes of IgGs are negative. So this is a MPGN process which is being driven by an IgG3 kappa monoclonal immunoglobulin. And in this circumstance, looking at the proliferation, your diagnosis is proliferative glomerulopathy with monoclonal immune deposits. So this then introduces us to the concept of MGRS, monoclonal gammopathy of renal significance. This applies to any B cell or plasma cell clonal lymphoproliferation with both of the following characteristics, and this is very important. One of the kidney lesions is related to the produced monoclonal immunoglobulin, and second, we don't have cancer. The underlying B or plasma cell clone is not cancerous. It is in the monoclonal gammopathy range. Once it becomes a cancer, it graduates. And the idea is that you're not looking at tumor effects. You're looking at the protein effects. So when you have a monoclonal gammopathy, which we used to say of unknown significance, it's in a small enough amount that there's no tumor burden causing any problems, but the protein itself is leading to problems in many different target organs. And when that happens in the kidney, you've got an antibody-producing cell like a plasma cell or a B cell, which proliferates monoclonally and can then provide this protein in the blood called, this is a monoclonal gammopathy. We used to call it MGUS, especially if there was no consequence to this detected. But if it is depositing in the kidney and causing a problem, we will call it monoclonal gammopathy of renal significance. Obviously, if you've got fragment malignancy, you're out of the MGRS spectrum. And these monoclonal antibodies can cause direct problems by depositing or activating complement in the tissue or causing a proliferation in the tissue, and they can cause indirectly problems with the complement as well in the fluid phase. So their manifestations would depend based on where they are depositing. So they can deposit in the blood vessels, they can deposit in the glomerulus, they can deposit in the tubules. And then based on what they're doing, when you have an MGRS-related disease, you look at their deposits. If they're organized and fibrillar, you're looking at some of these diseases. If they're microtubular, you're looking at some of these diseases. And if they've got inclusions of deposits, you've got these diseases. Some of these are rare, some of these are not very rare. Amyloidosis is not rare. Immunotactoid is a little bit of a rare disease. On the other hand, if these deposits are not organized, then you can have what is known as MIDD or PGN-MID. The case that I showed you a little while ago was an IgG3 kappa-driven PGN-MID. Now, there are two exceptions to the rule that you need a monoclonal immunoglobulin demonstrated in the tissues to make this diagnosis. One of them is C3 glomerulopathy, because the monoclonal protein itself can act as a it can actually act as a nephrotic factor itself. So you don't really need the monoclonal protein to be demonstrable in the tissue in these circumstances. And about 2/3 of cases of C3GN in adults are actually related to a circulating monoclonal gammopathy. And the other thing is the protein can be directly toxic to the endothelium and lead to a thrombotic microangiopathy, but you won't find the protein in there. In the interest of time, I will skip through that and graduate to the next group of disorders called focal necrotizing vasculitis and crescentic disease. The chief disease that we talk about in this is ANCA. ANCA antibodies are produced, which can actually target prime neutrophils. Prime neutrophils actually express PR3 and MP on their surface, and they're primed through an infectious process, like a synpharyngitic infection or something or the other. And then when you have these ANCA antibodies on top of these neutrophils, it causes a massive inflammatory reaction through these neutrophils. They release histones and nets and other evil characters, which lead to vessel inflammations, thrombosis through endothelial damage, and the net remnants actually signal through the innate immune system and persist in generation of antibodies. So this is another cartoon on how this happens on the endothelial surface. Imagine this is your endothelial cell in the glomerular capillary. You've got these neutrophils laying out these minefields of evil humors. This leads to activation of the endothelial cell, generation of stimulation of inside-out signaling, as well as damage to the endothelial cell in toto, release of several inflammatory hormones from the endothelium itself. When you have these integrins and p-selectins expressing on the endothelial surface, that leads to stickiness and margination. So when you look at these kidneys under the microscope, the one thing that you don't see, and this is why I put the electron microscopy first, you don't see any deposits. So if this was lupus leading to a problem like this, you'd see deposits all over the place. But since what we are seeing here is an inflammatory activity by neutrophils, which are actually damaging this endothelium through these various mechanisms, there's nothing to lay down as deposits. But what you do see is intense damage and necrosis. So this is Mason's trichrome, and what you're seeing is these fibrinoid necrosis, florid fibrinoid necrosis patches in this glomerulus and on the right side in an artery. So your artery wall is damaged, and all you're seeing is this fibrinoid necrosis. And this is because your neutrophils have come in and essentially shredded the endothelial surface. Now, this is a picture to point out how crescents form. So this is a glomerulus in which you see this intense fibrinoid necrosis. Now look at some of these capillary loops. These are okay. So this is focal necrosis, this focal point where there's a lot of fibrinoid necrosis. And then what you see is the basement membrane has actually been destroyed here. Once basement membrane is destroyed due to any process, this could be ANCA-associated vasculitis, this could be lupus, this could be IgA. Sometimes even in severe membranous, you can see crescent formation. So what happens is this material, this fibrinoid necrotic material, oozes out into the urinary space and causes an activation of the epithelial cells. And when that happens, you have massive epithelial hyperplasia. So you see here, this crescent is actually compressing the glomerulus down. The glomerulus is all collapsed here, and all you see here is a crescent. So that's what leads to crescent formation. So in this particular case, you can see this area of necrosis breaks in the membrane. That probably led to exudation of this goo inside the urinary space, stimulation of the parietal cells, and crescent generation. And this just tells you, whatever reason this is happening, it's causing a lot of damage to the glomeruli. So now we switch gears again and look at damage to the endothelial cells directly, which lead to the next group of disorders, which is the thrombotic microangiopathies. So in the kidney capillaries, there's 3 different types of endothelia. One of them is the endothelium in the blood vessels, which is a fairly typical endothelium. But the endothelium in the capillaries, in the glomerular capillaries, is very different. It is a fenestrated endothelium, and there's a similar type of fenestrated epithelium seen in the peritubular capillaries as well. And the glycocalycial and other spatial and physicochemical properties of these endothelia are different from your typical endothelia that you'll see in the blood vessels. So this is what a healthy endothelium should be doing. Healthy glycocalyx, no shear-induced stress, and if there is some damage or issue that comes up, it is quickly repaired. But what happens in TMA is that there's an inciting event, whatever that event may be. It may be TTP, it may be HUS, it may be antiphospholipid syndrome, it may be lupus. It causes massive damage to the endothelium. Once massive damage to the endothelium happens, the endothelium becomes unhealthy, and eventually microthrombosis start developing, different mechanisms for that. That actually leads to microangiopathic hemolytic anemia. So at this stage, you'll find schistocytes and thrombocytopenia, and eventually this leads to widespread organ dysfunction, which then manifests clinically. And this is what the unhealthy endothelium looks like. So it is activated, the coagulation cascade is interplaying, the inflammatory cascade is interplaying, the complement is right in the middle of all that. This leads to damage to the endothelium, generation of an inflammatory response, and hopefully at some point, if you're able to get over this, this can repair itself, and this can repair itself completely. So especially in acute processes like an acute antibody-mediated rejection, which sometimes presents like a cluster bomb went off in the glomerulus. Once you treat it, a month later you biopsy them again, and it looks healthy. But at the height of its disease process, what you see here is again something that looks like like an MPGN type pattern, right? You see this increase in mesangial matrix. You see complete loss of the capillaries. You don't see any capillary lumen here. This is a bloodless glomerulus, but you don't see a lot of cellularity here. So essentially what's happening here is that your endothelia are so swollen that they have kind of blocked off the capillaries, right? So this is classic TMA. So when you look at this under the microscope, when the pathologist looks under the microscope and sees a bloodless glom like this, but not a lot of hypercellularity, they would start wondering about thrombotic microangiopathy. Panel 2 here is a thrombus in an artery. Panel 3 is stained with Marcia scarlet blue. You got erythrocytes, degenerating erythrocytes in yellow here, and fibrin thrombi stained red on the state. So you've got fibrin thrombi and dying RBCs in the capillary lumen. So that's your microangiopathy happening right in front of our eyes. This is fibrinoid necrosis in an arterial wall. This is again Marcia scarlet blue. And this doesn't show up well because I made the picture too small. But if you look at a PS, this is a PS, which is good for basement membranes. You actually start seeing duplication of your capillary lumen. So once this stays long enough, you will develop the complete MPGN lesion. And the only difference here is that when you look at this MPGN lesion, all you see is fibrin. So this is an EM which is looking at fibrin in these glomeruli. So when you stain this glomerulus or this glomerulus, the IF will be negative. The only thing that will stain up is fibrin. Sometimes the IF may be positive if the TMA is secondary to, for instance, an acute antibody-mediated rejection, in which case C4D will light up, or if it is because of lupus, in which case you'll see some antibody-mediated activity.